Okay, good evening, everyone. For those of you who don't know me, my name is Valerie Phelps. I'm an event specialist at the Michigan chapter of the Cystic Fibrosis Foundation. I'm really honored to be here speaking with all of you tonight. Before I go too far into the updates, I want to make sure you all know that this call is being recorded and the link will be sent out in the coming days with the full recording. So this year has continued to look very different for all of us. We're still very grateful to work very closely with the Care Center staff here at the University of Michigan by combining our technology and the center's information for various updates while everyone has remained at home. We still miss seeing all of you guys very dearly, but know that we're still here and we're still working hard for each and every one of you. There's quite a few ways in which the CF Foundation has continued to move forward during this past year. We all know that CF doesn't stop just because there's a pandemic, and we don't stop fighting for better quality of life, better treatments to make your day easier, and of course, a one-time cure for every person living with CF. Just a few of the biggest highlights of the past year from the CF Foundation include, we've provided additional support to all of our care centers through telemedicine, along with providing over 10,000 home spirometers. We've invested nearly $74 million to fund over 380 projects with the purpose of identifying new science and potential treatments. We've started a new program to advance a bioengineered pancreatic enzyme replacement therapy, which is one of the biggest advances in this particular area in the last 2 decades. And also we've increased our medical budget by 25% from 2019 to 2020, larger than any other time in our foundation's history. Our researchers and scientists are working to harness some of the most innovative ideas in medicine to help those with CF. And last but not least, very exciting, we're closer than ever currently to expanding Trikafta to children ages 6 to 11, and this could be approved as early as next month. There's a lot of amazing things happening, but we cannot stop now. It's important to continue to fundraise to further all of this exciting research. I now want to give you a few couple updates from our chapter. We just recently held last Saturday our 2021 virtual Great Strides Walk. We're so grateful to everyone who participated this year. There is a new Fight CF app that incorporates Great Strides, Cycle for Life, Extreme Hike, and CF Climb. So all of those events are now in the one Fight CF app. The app itself has an activity tracker built in. It has the ability to deposit checks and easily keep track of all fundraising and messaging in one simple app. This is exciting news as we're currently gearing up to host our second annual 65 Roses Challenge kicking off on June 5th. The challenge will run throughout the summer and end on August 8th. You can join in by registering for either Great Strides or Cycle for Life. People who participate are encouraged to pick an activity of choice. You can walk, run, hike, or cycle. There are some people even choosing to swim, rollerblade, or dance their way into 65 days of activity. And then as far as our fall events go for our chapter, our Evening with the Stars event is continuing to be under quarantine again this year, but we're bringing back our virtual Cooking and Cocktails for a Cure on October 16th, 2021. If you weren't a part of the event last year, we would love for you to join in this year. It was a really good time and a really fun event. And then our finest event for young professionals will be taking place on November 5th, 2021. More information will be coming soon on how you can get involved and invite young professionals in your life to also get involved. With all the events of the last year, I also wanted to take a few minutes to remind all of you about Compass. Compass is a branch of the foundation that handles all insurance, legal, financial, and other life issues. In the last year, they took nearly 1,000 calls related to COVID-19 alone. They're still hard at work helping with issues such as job loss, food scarcity, vaccine allocation, and a ton of other things. Please keep them in mind if you have a need. They can be reached at 844-COMPASS or compass@cff.org. Now, finally, for a little bit of housekeeping, you can use the Q&A feature for any questions you may have, and then you can use the chat feature to give shout outs and make comments. The Q&A will be monitored during the entirety of the call. If you have any questions, the appropriate member of the care team will do their best to answer. If we can't get to all of the questions for some reason, they'll be answered after the call. So if you do use the chat feature, please be sure to change it to all panelists and attendees so that it can be viewed by everyone on the call. Thank you for allowing me to speak with you this evening. Our entire staff, Shelley, Marielle, Abby, Haley, Carrie, Ariane, and myself want you to know that we miss you all and can't wait until we can see you again face to face. Thanks again, and now I'll turn you over to Dr. Nasr.
Okay. Good evening, everybody, and thank you very much for logging in and being part of this session. I'm going to share my screen. Okay, can everybody see it?
Yes, it looks great.
Okay, great, thank you. So just a little bit of housekeeping again, like mentioned. Okay, it's not moving. Here we go. We'd like to thank our sponsors for this evening. We would love to have them in person, but maybe next year. Gilead, and I'm just going the direction this way. Gilead has been always very supportive. Vertex, absolutely very supportive. Vyvanse and Chiesi, and really helping us out with this function. So thank you very much. This is a list of the people attending. So from the the local CF chapter, which we really appreciate all your help, and really thank you very much for all what you're doing for us. We'd like to thank Carrie McLaughlin, Shelley Francis, and Valerie Phelps. And I think there was another person, Valerie, that you mentioned. If you want to mention them, that would be great.
Yeah, so on this call is myself, Valerie, Shelley, and Carrie. The rest of our staff includes Abby Stappa, Marielle Boza, Haley Malloy, and Ariane Scherer.
Okay, thank you, everybody. You guys have been great for us and been really very supportive and making our life a lot easier. From the Michigan medicine side, we have the adult and the pediatrics. We have Dr. Sisson, Gia, Philbrin, Caverly, Ramirez, Lewis, which is not on the list, but she said she'll be there, Toby Lewis, Ronnie Downer from the adult side, Don Cruz, our research manager, Marissa Lynn and Jessica Carey are our research coordinators. Jordan Steffler is one of our nurses. Adam is PSA, Patient Services Assistant. Julie and Haley, both are our social workers that are doing an awesome job with our patients. Stacy, and I actually saw Courtney as well, our dietitians. And then Hannah, our pharmacist, and Liz Barron, the inpatient nurse leader that we usually go to her with anything and everything we need. So moving on to my presentation, which is mainly I'm going to be talking about the changes that we had in our center, in the pediatric center in this last year, which has been really very interesting. And also I'm going to go over some of the data from the center from 2019. I have to say we just got the 2020 data today, so I didn't really have time to go through it, so we'll do that next time. So for developing, so, you know, just to go through the timeline, in March 10th, we had the first 2 cases of COVID-19 in Michigan. Till then, we were kind of thinking we're safe. March 13th, and it was a Friday, and we you know, they stated that that's it. Last person in clinic held, and the lockdown started. So we all went home practically. And then we took a few days to kind of get it together. And then by March 18, we have the interdisciplinary team began working remotely. So what happened is that the physicians were able to do video visits at that time, and then it was ramped up through the days. After that, the support staff were doing really more of a phone follow-up to keep up with the patients, then gradually got their video visits as well. So the process was just rolled in gradually, but quickly as well. In May 27, the hybrid model started. At that time, we started to see some patients in clinic. So we decided, okay, enough already. It's been more than 2 months, close to 3 months. And we really need to see patients in clinic as much as we can to get their labs done, to get their throat cultures, and pulmonary function testing. Now the Holmes parameters were not at that time available for patients. So we started seeing some patients, but at the same time, our nurse was also in clinic with us, but the dietitian, social worker, and pharmacist were doing virtual or remote clinic visits. And they do it most of the time before the physician's visit, but sometimes they will do it afterward or follow up afterward after they come to clinic to follow up with the weight and the height and such. So currently, most visits are with the MDs and nurses are in person. So I would say probably 85% of the patients are seen in person, and about 15% seen virtually. Might be 80-20 kind of thing. That's really helpful to lay eyes on the patients, get them done, and see how they are doing in general. But our dietitian and social worker have been doing joint virtual visits, and then the pharmacist does it remotely beforehand in most of the patients. So the staff and the patient's family, dedicated and we did questionnaires to families and to patients to see how satisfied are they with the virtual world, and there was actually some satisfaction. I mean, we're in a unprecedented time. So, but the staff and the patients and families were thinking that's flexible. That's a good idea that we were able to do that. The other thing is, is the virtual here to stay? And the answer is, I think so. I don't think we're going to go all to in-person visits for all our team. We will have the dietitians and social workers and the pharmacists in clinic gradually, but I think there will be situations for follow-ups, people coming in from a long distance and there is a snowstorm, or there is, illness in the family. So there will still be using getting patients seen virtually as well. When there is a virtual visit with a social worker and dietitian, they ask them about their agenda. What do you have? What's in your agenda? What do you want to ask the physician when you see them, or what do you want to ask me? And then the pharmacist would ask some question. I ask the same question. So there is redundancy on repeating to ask the same question, but that's good because sometimes they forget to say something to one of us and then they would remember with the other one. The other thing is they might get an answer, from the dietitian, for example, but I can answer part of it as well. So it's been really very helpful. Telehealth are good for travel barriers and help some patients be more engaged. And I have to tell you the babies, especially, the parents have been really appreciative because the social worker and dietitian can follow closer. So they are not just seeing them once a month, they are seeing them in between and adjusting things for them, working around their schedule. So it's been very helpful to the families. What we do is we don't do synchronous visit, meaning we don't have everybody at the same day available to do the video visit, because we thought that would be too much for the family to sit through several virtual, then see in person in clinic. So we're doing it asynchronous. So they see them within a week before the clinic, and then afterward if they need to. There are some challenges, of course, to telehealth. Some parents schedule with like for 48 hours before. That was very short time. So we worked actually with Children's Special Health and Medicaid to help improve this time frame, which that's what they want us to do. They want us to see patients within 48 hours of their physician's visit. And they were able to extend that to make it a week, within a week, and other insurance followed. So that was very helpful. Some of our families are not having access to the portal. So when we started the lockdown, about 40% of our patients have access to the portal. So we quickly started communicating with families, sending messages, calling them. And now we have about 90% of the patients are on the portal, which is awesome and great. So we can send messages, we can see them through the portal virtually. But there is about 9% of the families don't have access to the portal for various reasons. And we were able to do phone visits or non-portal Zoom visits, which we can, actually our secretaries can organize that and send the link to both us and the family. The problem is also there is no culture, limited lab x-rays, and lung function was a problem. And for our CF Center grant, we really need to have cultures every 3 months, also for close follow-up of patients. But the CF Foundation was very helpful in kind of loosening the guidelines for this year. The other thing is with the lung function, we were able to have the home spirometers from the foundation, which, we didn't pay for it. That was great. And now most of our kids 6 years and above are having a home spirometer. Sometimes it's hard to get them to do it. It's not the easiest technique to do, but they've been doing it. And I usually ask them to do it, especially when there is a video visit with me, or when they come in and don't have their COVID testing, then I need to have one. So they usually send it to me. And again, through the portal is a great thing. So in summary, asynchronous interdisciplinary team telehealth can be used for our CF clinics in care from routine, follow-up and sick visits as well, or follow-up visits. For education, RT can do their education instead of you hauling all the way your equipment here. They can do it virtually, and that actually would be great because then they can see where the equipment are kept and can give you some tips on that as well. We're unsure how the business and school reopening will change parents and patients' availability. So we sometimes it's easier for them to just come one day and do everything, but that will be available as well as we go on. So we'll see how it goes. So it's a new day, and it's a changing landscape every time you turn around. Now, the dietitian and the social workers, like I said, in March of 2020, with the pandemic starting, they both tag team together to make it easier for families. So that way, it's not a lot of phone call to schedule, but also you're not killing two birds with one stone, if you will. So in April of 28th of last year, they were able to initiate virtual visits. Before that, it was mostly phone calls, and they've been doing it. I think it's been working very well. The virtual platform allowed the dietitian and the social worker to combine appointments. And also more close follow-up of the dietitians to families and social workers as well, as needed. I get a lot of messages from the dietitians in between visits telling me that they called and they adjust medication, they did some, so it's really cool that they are following up with the family closer. The virtual model allowed them to significantly increase contact with patients that need it, not just doing it. If you need it, they'll do it for you, or if they think that it's needed. Continuity of care and following patients more closely resulted in decreased hospitalization and better health outcome. And that decreased hospitalization is a very interesting topic. It can, I can elaborate on that for a while, but I think there were several factors that decreased hospitalizations. One of them is COVID. Patients were all sitting at home and not in contact with others, so they stayed healthier. The flu diseases and the viral diseases are a lot less this year because of that. Also, Trikafta came in the fall, and it's been making a huge difference in patients' ability to do better in general. So these two are, and then people are afraid to come to the hospital as well. So at that time, at the beginning, so practically we didn't have many patients in March. We have, I think, 1 or 2, none in April, none in May, and then June starts, and then kids were coming in. So it's kind of changing, and things are in progress. So this is while we were doing, right before the lockdown, we had an exercise, a home exercise program to help our patients. So we did a study before to test the strength of our patients, and that using hand grip strengths. And that's a little machine that you kind of push too much on it, and then they can measure your strength, and that reflects your muscle strength. So we had that done, and we realized that 40% of our patients are weaker compared to kids that don't have CF. So we wanted to carry on, and okay, we figured out, okay, some of them are, like 40% of them are weaker than they should. Then should we have an exercise program at home to see if that can help them? So we had our physical therapist, dietitian, one of our fellows, and Dr. Philbrin and I, part of it. And our physical therapist designed the high intensity interval training, or the HIIT exercise, and taught the patients how to do it. And that was right before COVID hit. And the plan was to see them in 3 months and in 6 months and measure their strength and follow up. Of course, things fell apart, but we were able to connect with these patients, of course, way later, not really 3 months, it was like 6 months to 8 months. And there was greater volume of high intensity exercise during single exercise session compared to moderate intensity continuous exercise training. So we wanted them to do the HIIT program because it's in a shorter period of time, you can do a lot more than moderate intensity. And that would reduce the burden of care and maximize airway clearance as well. However, we wanted them to do it, but they do it. So it includes 5 minutes of warm up, and then 16 to 24 minutes of the HIIT exercises, and it's 5 to 6 exercises. And I'm not going to go over the details of it. And it's recommended 3 to 5 times per week. So we were very excited, that sounds like a good plan. I actually tried the exercises myself, and I thought it was very helpful. So we tested 40, or we worked with 40 children, and then 30 of them came back. And like I said, between 6 to 8 months from the beginning of that project. But only two patients reported participation in the HIIT program. One of them stopped it after 1 month because he thought it was too difficult, and the other one just continued. However, we asked the individuals to see, are they doing something different? And they were. So yes, the HIIT program, we thought it was great, it was wonderful, but it doesn't really matter when you test it in real life is what is important. So I think by alerting them that exercise is important, there was several patients that really started to do moderate exercise. And some of them were exercising before, so they just continued, even though there was the lockdown. So We know 40% of the children with CF were found to be relatively weaker, and that was actually from reviewing the literature as well. Implementation of the HIT program was unsuccessful. However, we were able to encourage children to either start or continue moderate exercise. And most patients recorded improvement in strength by the absolute grip strength. And so we saw significant improvement in these kids that did moderate exercise. And with no change in the BMI, of course, because it's such a, BMI percentile, I wasn't surprised when I saw that because the BMI is, could be normal with kids that are weaker. So wasn't really purposely doing that. Well, how about our transition program? Our transition program, we usually have our adult colleagues come in to see the patients with us, and we usually have them meet and greet in the clinic. When COVID hit, we stopped that, and we actually waited a little bit till we kind of got things together and discussed it between the two groups, the pediatric and the adult group, and we agreed that we can do it virtually. So we've been doing these are all reported to the CF meeting coming up as well. So we were able to use the meet and greet virtually with patients. And Kathy actually did a questionnaire for patients that went through virtual meet and greet versus they did in-person meet and greet, and the satisfaction from both groups were very similar. So additional tools during the pandemic, our administrative support been working remotely, but to tell you the truth, other than not seeing them physically in the office when I go, I'm not seeing any difference. They are really very available, very helpful, doing wonderful job for us. So, and hopefully the patients as well. The home spirometer has been a wonderful tool for us to use. And there was also home scales that the social worker were able to get to patients that need it. So if family don't have a scale and they need one, she was able to get that for them, which has been very helpful. And a lot of them are very close to our scale in the clinic as well. COVID, and I have to put a plug for COVID vaccination. So for 12 and above, please, all people with CF should get that as soon as they can. I don't think there is any exception for that. And if you have any question, just let me know. So now I'm going to spend a few minutes on the review of center data, and that will go quickly. So for 4 visits or more clinic visits per year, we're at 75%. That's been work in progress. Everybody in the office is involved in it. And then we are above national average, which is wonderful. And you can see from this, each increase in the red line, which is our center, that's a QI start here, quality improvement project, and you can see improvement. Then things kind of settle down, and then we try different things. It's not working, and finally, in 2017, it worked. 2018 went much better. So right now we have another QI, work quality improvement work to help improve it. So hopefully that one will move as well. This is our median WHO weight for length group. And this group has been very difficult for us to get them to gain weight and be the weight for length to be above the 50th percentile. And now we also are above national average, which is a great thing. BMI for 2 to 19 is also good. Now remember, we aim for 50%. So 61 is great because we really wanted to make sure that if they get sick and lose weight, not to drop below 50%. And this is just to show you how we've been doing that as well. And also that it's been a lot of quality improvement work to improve that BMI. It is the pulmonary function testing. And you can see just, like looking at this number here, we're at 98.5%, which is great. We're above national average, but not by a lot. And that is because they're both like above 95%. So you really are way above anyway. And this is how it looks. And this is for 13 to 17. And again, above national average. And both of these are really the BMI and the pulmonary function testing have been quality improvement work constantly to get things better. It is for 18 and above in the pediatric center, also above national average. And you can see, so here that's interesting because what happened is that other centers actually caught up with us. So we were at 90% here 10 years ago, and we're still about 85. So we didn't really drop that much, but the other centers really caught up with us. This one is for pulmonary exacerbation, and that's important because we always call pulmonary exacerbation more than other centers nationally. And that is helping that's part of the quality improvement work for improving the FEV1 or the spirometry. So we usually call pulmonary exacerbation faster and treated more. And this, you can see that we're way above the national average for that. This one, the IV antibiotics treatment duration, we're very close, very similar. This one just to show you the bacteria that the kids are growing in. Pseudomonas, for example, we're below national average. MRSA, we're at the same, and then goes on and on. This one, it just shows you the treatment the patients have been having, and that you can see that these are patients 2 to 5 years old. About 92% of them are on pulmozyme, Toby, whenever or tobramycin inhalation solution whenever they need it. So very, much above national average. You are more aggressive in treating that, treating patients as well. This one shows you the modulator. And remember, that's from 2019 data. So things really have changed quite a bit. We have more patients. So right now you can see ivacaftor is about 60% of the patients that need it are on it compared to national. Now the Orkambi, very small number of patients are on it compared to national because a lot of these patients moved on to Trikafta. Same thing with the Semdeco, even though it's close to national average, but whenever patients qualify for Trikafta, we move them to it. So this is the last couple of slides. The FEV1 versus BMI percentile for patients 6 to 17 years of age by program. So the foundation does a really nice job with it. This is all summary of our data that's sent by the CF Foundation. So that's why we would like all patients to be part of the CF registry so that we can get our data together. So in 2009, patients, in our program was at 93.8%. Now in 2019, 94.5, improved by a little bit. But the BMI was a lot better improved from 57.9 to 62.8. So that was significant improvement. And then you can see that nationally, the numbers are there. And this is another way to look at it. This is where we were not 10 years ago, and this is where we were now or a year ago. And that you can see the more you move this way and above, the better you are. So we're on our way. And this one is for 18 to 30 years of age. In our program, of course, 18 to 21 is what we have. We don't have 30 years old. So you can see also that improved in the last 10 years quite a bit. This is the median predicted survival for CF patients. And you can see where we started when the CF was identified, the disease was identified in 1938. Survival was less than a year of age. and then gradually it's been becoming much better. And right now we have no idea where that's going to go. I think it's going to keep going up and up. We're about, close to 50 years right now. And that's it. Thank you very much.